Hello everyone, I am Dr. Pasyanthi from Anand Institute, Hyderabad, and I'm a glaucoma consultant here. So today I'm here to discuss an interesting case, the glaucoma that was round the bend. So a 16-year-old female came to us with complaints of blurred vision in the right eye. She initially went to a local hospital at Warangal with the same complaints, and there they had suspected glaucoma and they had referred to us. So her visual acuity in the right eye with minus 9.5 sphere is 6.6, and left eye minus 8.75 sphere, it is 6.6. And the conjunctiva, lids, cornea, they're all normal. The anterior chamber depth is Van Herrick's grade 2 and it is shallow. And the pupil was round, regular and reacting. And intraocular pressure with Goldman applanation tonometry was 42 millimeters of mercury in the right eye and 44 millimeters of mercury in the left eye. Undilated disc showed significant damage in both the eyes. So the gonioscopy revealed that she had angle closure, occludable angles with sine K in both the eyes, both right and the left eye. And this is the anterior segment photograph in the right eye and the left eye showing a Van Herrick's grade 2 and a very shallow anterior chamber. Now, what is unusual in this case? So you have a young girl with a shallow anterior chamber, occludable angles with sine K, and you generally expect hypermetropia in these patients because hypermetropia is what we see in angle closure, but we have high myopia in these cases. She almost has minus 9 and minus 8 in the right and left eye respectively. So what is unusual? The high myopia along with shallow anterior chamber. Now what are the causes? Plateau iris, which we can rule out only after doing a peripheral iridotomy. Drug-induced angle closure, we have asked the patient if she had used any medication. She was not using any medication systemically. And malignant glaucoma, she did not undergo any surgery. So microspherophakia is one probable diagnosis we were having in mind. So what is microspherophakia? It's a rare congenital anomaly and which has a biconvex spherical lens with reduced equatorial diameter, and it is the developmental anomaly of the zonules, and it is usually bilateral, and the mutation in LTBP2 and ADAM-TS17 has been reported. Now, what are the ocular associations? You can have lens subluxation, or you can have dislocation of the lens either anterior or posterior, or you can have high myopia, accommodation deficits, and raised intraocular pressure. And systemic associations, it is associated with homocystinuria, Marfan syndrome, Weil-Marchesani syndrome, and Alport syndrome. So the management in these cases, if you have only myopia, then refractive correction is enough. And if you have pupillary block, peripheral iridotomy needs to be done. And if you have angle closure glaucoma, cycloplegics can be given, and peripheral iridotomy has to be done, and anti-glaucoma medications. And if the IOP doesn't get controlled, then you need to do a trabeculectomy or a glaucoma drainage device. And in case if you have a lens subluxation, then lens extraction is needed. So in our case, we had angle closure glaucoma because the patient had glaucomatous disc damage as well as occludable angles. So we went ahead and did a peripheral iridotomy. Now, what is important? You do not use pilocarpine in these cases because pilocarpine can increase the anteroposterior diameter of the lens further and can exacerbate a pupillary block. So without pilocarpine, we have done the peripheral iridotomy, and this is the post-dilated picture where you can clearly see the microspherophakia, the spherical lens in right and the left eye. So this is the disc photographs, the right eye showing a medium disc 0.9 bipolar notch and the left eye showing an inferior notch with a superior near notch. So we have advised anti-glaucoma medications in both the eyes, and we also ask the patient to have a systemic evaluation. Now, what are the pearls from this case? So when you have myopia with shallow angles, always rule out uncommon causes and do not use pilocarpine when you are doing a peripheral iridotomy. And when you have a pupillary block, definitely YAC peripheral iridotomy is the treatment of choice. And in case the IOP doesn't get controlled, trabeculectomy needs to be done, and you always rule out systemic associations. Thank you.